Good morning, and welcome to Pediatric Grand Rounds. It is my pleasure to introduce to you today's speaker, Dr. Rebecca Schreier. Dr. Schreier was born and raised in Billings, Montana. She obtained her Bachelor's of Science degree from Montana State University in 2008, majoring in biology. She worked for 2 years as a CNA before traveling to Lewisburg, West Virginia, where she attended the West Virginia School of Osteopathic Medicine, earning her Doctor of Osteopathy in 2014. She joined our Sanford family as a member of our pediatric residency later that July. While a pediatric resident, she has distinguished herself as an outstanding clinician in both the inpatient and outpatient environments. During her residency, she has extended her own family with the birth of her son, Reed. She has been described by her clinical instructors at Sanford as an exceptionally good resident, an excellent teacher who has a strong medical knowledge. She is truly one of our best residents. She will be graduating this June and continuing to support our Sanford family as a pediatric hospitalist in Fargo, North Dakota. She has co-authored 2 publications in South Dakota Medicine and 1 review article in Medscape, all in the field of infectious disease. Today, she will enlighten us with her talk entitled Febrile Infants, Decreasing Length of Stay. Please help me welcome Dr. Rebecca Schreier.
Thank you, Dr. Messier. All right, good morning. So, like he said, I'm going to be continuing on as a pediatric hospitalist in a couple of months, and so I tried to pick a topic with something where I wasn't exactly sure on how we manage some of it, and since you guys are going to kick me out in a couple of months, I figured I should probably figure something out and do a little bit of research. All right, and so for my objectives, we're just going to talk a little bit about the standard workup for febrile infants currently, what are the recommendations for the treatment, and then looking at some new articles that have come out to see, is it cost effective and is it safe to decrease the length of stay for febrile infants? And then I have no disclosures. So the traditional teaching is that, for neonates or infants less than 90 days, if they have a fever greater than 100.4, especially for the ones less than 28 days, that they're going to have a full sepsis workup. They'll be admitted and they'll get 48 hours of antibiotics until the cultures return. And then we're also currently taught that the most common bacterial causes for febrile infants are going to be your GBS, your E. coli, and then your Listeria in that order. And then for the 29 to 90 days, it's kind of using the criteria of your choosing, whether it be the Rochester, your clinical judgment, to guide your management and just kind of your clinical experience. So just a couple of definitions before we continue on. So spontaneous bacterial infections, those are going to be your meningitis, your bacteremia, and then your urinary tract infections. And then for the invasive bacterial infections, that would be meningitis and bacteremia. So several studies have looked at the variation in the care of febrile infants. And they found, that fever is a very common problem, and that many of these infants, it's the only sign that they have for a serious bacterial infection. And the prevalence of serious bacterial infection in several articles really ranges from about 8 to 12.5%, and higher in those less than 28 days, and in some articles it's actually up to 20%. So they noticed the variation, and then they tried to survey some different fellowships and residencies to see, and some providers to say, well, why is there such a variation in our practice? And so when they looked at a pediatric EM fellowship, they found that less than half of them actually reported that they followed any guidelines. And that only 36.7% of pediatricians report that they follow guidelines consistently. So they said, well, why do you vary your practice? And many of them said, well, we rely on our clinical judgment, and based on the clinical presentation and the severity of illness, helped guide our treatment. So we know that there's a lot of variation in testing, treatment, and then the hospitalization rates. So an article in 2016 in Pediatrics looked at the management and outcomes of the previously healthy term febrile infant, and they found that only 59% of the less than 28 days actually had a full sepsis workup, even despite that this population has the highest rate of serous bacterial infections. And then from the 29 to 60 days, it was the 25%, and then the 5% for the 61 to 90 days. So 61.3% of the febrile infants less than 28 days were hospitalized. But of those that weren't hospitalized, 13% documented that those infants were moderately to severely appeared ill. And then 25% of the infants less than 3 months had some type of culture obtained. So they also kind of looked at different practices and different type of providers to try and see if they could also evaluate why they vary so much in their practice. And they kind of noticed that providers in the same practice tended to practice similar with the management of their febrile infants. And so they thought that maybe due to joining a practice, you would pick someone that practiced similar to you or had the similar risk aversion. They also found that low-income population had more aggressive treatment approach, and that seemed to come down to they were a little bit nervous about any barriers for them to be followed closely. So the variation observed in acyclovir was also kind of impressive. So even though that HSV infection is associated with high risk of mortality and morbidity if untreated or delay in treatment. So the HSV incidence is low, especially in infants who are clinically well, or if they don't have any clinical manifestations like vesicles, or if their CSF has any abnormalities. So the neonatal HSV is especially uncommon in after 21 days, yet 12.4% of the febrile infants received acyclovir that were 29 to 56 days. All right, and then in 2013, again in Pediatrics, an article, The Epidemiology of Bacteremia in a Febrile Infant in the US, kind of talked about the epidemiology that we're noticing now. And so 2% of infants presenting with a fever without a source will have bacteremia. And now E. coli is now the most common cause of bacteremia in less than 90 days. And then GBS is now second, which has actually dramatically declined. So intrapartum antibiotics prophylaxis has really helped reduce the risk of GBS, especially the early onset sepsis. And then they also looked at, so currently ampicillin plus gentamicin, or ampicillin and a third generation cephalosporin are currently what we use to treat these febrile infants, which for right now is also kind of a unique topic in the fact that ceftazidime is something that we usually use, but we're kind of on a shortage right now, and so there has been some discussion of other facilities what they are using, and so they looked at using ceftazidime and then also ceftriaxone, knowing that ceftriaxone, of course, if babies have any risk for hyperbilirubinemia, then that would be not a good idea to be using that. All right, so ampicillin is used to cover for your Listeria and your Enterococcus. Several of the articles said that they actually had no cases of Listeria reported, even though there were a couple of Listeria outbreaks during some of these articles. And Listeria, it's not a common foodborne infection. They think the decrease is due to prohibition regarding the sale of any contaminated foods, and then also we've done a better job of educating some of the high-risk populations like pregnant women. So now this article talked about, in order that the E. coli was going to be the #1 cause, GBS followed by Strep pneumoniae and Staph aureus, and then Listeria they had no cases, so it actually really wasn't on the list. And then Staph aureus is now an emerging and leading pathogen in bacteremia, which poses several problems to treatment if they develop any methicillin resistance. And then the emergence of resistance especially is increasing the gram-negative pathogens. So 80% of the bacteremia is caused by gram-negative pathogens. And so 61% is going to be E. coli, and of that, E. coli causes 92% of the urinary tract infections, 54% of the bacteremia, and then 44% of meningitis. So there's concerns with gram-negatives because they also can develop ESBL or an inducible AMP-C, which makes treatment very difficult. So the remaining 20% are now kind of gram-positive that cause the serious bacterial infection. And interesting, about 45% of the gram-positive already have resistance to ampicillin, and then about 55% of gram-negative have resistance to ampicillin. So this kind of brought up a question in this article is there a possibility of maybe just using a third-generation cephalosporin instead of using both of them together with the resistance and knowing what type of bugs are most common? So this article looked a little bit too at why are we having increased resistance. So maternal antibiotics use during pregnancy and delivery, as well as postnatal antibiotic exposure in the infant may potentially influence the resistance that we're seeing in the epidemiology of the bacteria pathogens that are now causing serious bacterial infections. And the increasing ampicillin resistance of pathogens with neonates with early onset may also be due just to the interpartum ampicillin administration. And then they also looked at overall susceptibilities and in this article, and so as you can see, a little over 50% was already resistant to ampicillin, 3% resistant to ceftriaxone, and 2% to gentamicin. And then just to talk a little bit about blood cultures. So I like to measure the time to positivity for blood cultures. And so we know that blood cultures are now nicely monitored continuously by an automated machine. So we can have a continuous update. So once they are positive, they report it out right away. And so for this article in 2014 in JAMA Peds, they had a time to positivity, which was about 15.41 hours, and then the median was 13 hours. So just to kind of look at it, so the time to positivity was shorter in the less than 30 days, which makes sense given that they are a higher risk of serious bacterial infections. And then to put it in a little bit of perspective, after 24 to 36 hours, or after 24 hours, 91% of the blood cultures were positive, and then after 36 hours, 96% were positive, and then after 48, 99% were positive. And in this article, they as well found that E. coli was the most common bacteria to be causing the bacteremia at 41%, and that GBS was at the 27%. The Staph aureus was 6%, and the strep pneumonia was 5%, and so they switched a little bit just from the previous article, but pretty close in the third and fourth spot. And then just to look at numbers, so after 24 hours, to get one more bacteremic patient, you're going to have to evaluate anywhere from 5 to 1,200 febrile infants. And then after 36 hours, you're looking at evaluating 1,200 to 2,700 to get one bacteremic patient. And then after 48 hours, you're looking at 5 to 10,000 febrile infants in order to get one bacteremic patient. So it's just something to put in perspective, and as a provider for you to think, what are you willing to be okay with? Are you okay letting a patient go after 24 hours, or would you be more comfortable waiting longer? And then in 2004 in pediatrics, they looked at the risk of serious bacterial infections in young infants with RSV. So when we look at serous bacterial infections and viral infections, they found that if you had a confirmed viral infection, it does reduce the probability of having a serous bacterial infection from about the 12% to the 4.2%, and the bacteremia from 2% to 1%. So infants that were less than 60 days, they also found that if they had bronchiolitis or were diagnosed with bronchiolitis, they were found to have a serous bacterial rate of about 1.8%. They also commented that for the infants less than 28 days, that the risk of serous bacterial infection is really so substantial that they didn't feel that it was statistically significant to really count the viral infection to decrease the rate of serous bacterial infection, given that was only 10.1%. It really depended on one article and how high they had their less than 28-day risk or rate of serous bacterial infection, but overall they said that they just didn't feel that it was statistically significant. So another another way to help kind of evaluate your febrile infants, there's been some discussion on other labs that you could obtain. And so in 2008, they looked at procalcitonin in young febrile infants for the detection of serous bacterial infections. And really, I've only, in the last 3 years, ordered procalcitonin twice, and so wasn't really familiar with it. So this was kind of good to read about. And then, of course, we order CRPs routinely more to trend. So the white blood cell and the count in the ANC have had variable performance in detecting those infants with bacteremia and have actually decreased sensitivity in the younger infants. And so they found that the CRP levels were superior to the white blood count at screening for detecting the serous bacterial infection. And that in this article, they used the procalcitonin less than the 0.12 as an optimal cutoff value at identifying any infants with the risk of serous bacterial infection. So procalcitonin, it's almost undetectable in the physiologic condition, but it increases in things like pyelonephritis, bacteremia, and bacterial meningitis, which are things that we would be evaluating for in a febrile infant. So the procalcitonin does have a greater sensitivity and negative predictive value than other more traditional markers like the ANC, and that the sensitivity of procalcitonin was 93%, and then the specificity was 78%. And then just looking at the CRP, it's just a little bit less for the sensitivity at 89 and then the specificity at 75. Overall, the article kind of stated that they weren't really sure how reliable these markers would be in evaluating, but overall that they did better rule out serous bacterial infections if these were negative. And then just a little bit more about procalcitonin and the CRP. So things just to think about, kind of depending on your location. If you're doing an evaluation in a clinic, it may or may not really benefit you to order these labs because currently here, if you order these in the clinic, they have to be sent to the main campus to be ran, and so you're looking at a delay to really help you guide your management. So there's really not a huge cost difference between them, and the time frame is an hour and a half versus 45 minutes. But really, it's just going to be depending on what you have available to you. I mean, in the emergency room and in the hospital, these things are easily available, but if you're going to try this outpatient, this might not be something that you can use. And then another thing to think about is how long it takes for these to actually be elevated. So you're looking at someone needing to have an illness for at least 2 hours or to even have their procalcitonin increase. So if they present to you and they had just started having symptoms and their fever was really recognized just when they came to you, these also might not be very helpful to you. And then for CRP, you're looking at least 6 hours before it's going to start elevating. So the main reason to kind of talk about this is that the AAP is going to be putting out an update to evaluating and managing febrile infants guidelines. So this is pending, but in the statement that they put out, they talked about wanting to make guidelines for febrile infants from 7 to 90 days and really leaving out that first 7 days for the early onset sepsis because those would meet different criteria. And really they want to tailor their treatment based on the serous bacterial infections due to the varied incidence and clinical outcomes. So some inclusion criteria that they're proposing is that, so you have to be a full-term baby, so greater than 37 weeks. You have to be between that 7 to 90 days. You have to appear well on your physical exam, and that you actually have to have a documented fever or a reliable source, meaning it can't just be like a tactile fever. And then some of the proposed exclusion criteria are if they have any perinatal, prenatal, or neonatal maternal fever, if they have already had any infections, or if they have had antimicrobial treatment, or if you notice any obvious signs of infection or evident infection. And then being technology dependent, so if the patient is trached, they wouldn't meet qualifications for the guidelines. And then any presence of congenital anomalies that would really set them up for being an increased risk it excludes them from the guidelines. So really the goal is to stratify the management by ages and to provide the most appropriate and direct treatment. And so looking at the different ages, they have different risks of serous bacterial infections, and so they broke it down accordingly. So the 7 to 28 days, the 29 to 60, and then the 61 to 90. They did make a statement that it may include inflammatory markers to help include or withhold certain treatments and procedures if the infant is low risk. And then observation may be appropriate for certain infants. And they did say that it was expected in early 2017, and I'm not sure at what point we're not in early 2017 anymore. So we're kind of almost out of spring here. All right, so a couple of articles that I think may have contributed to why they may actually be thinking about putting guidelines out, since, over the last 10 years or however long, they've never actually made a statement on this before. So in 2016 in Pediatrics, an article with variation of the step-by-step approach in the management of the young febrile infant. So it looked at making an algorithm a step-by-step. And so it was a prospective looking at 11 European pediatric emergency departments from 2012 to 2014. And they felt, based on the data, that there was a better sensitivity than the Rochester criteria or the laboratory score to identify the low-risk patients that were able to be treated outpatient. And the lab score really just is a score based on their CRP, procalcitonin, and then their urinary dipstick. So they really looked at the general appearance, the age, and the urine dipstick. They identified 80% of the serous bacterial infections in the infants. I will say that 7 patients were initially classified of low risk, but were found to have a serous bacterial infection. So that was about 0.7% of this population. And so they felt that it was because that the fever was actually less than 2 hours when they did their evaluation. And of the 7, 6 of them had bacteremia, and 1 of them did have sepsis. So they looked at classifying infants into either a high, intermediate, or a low risk. So they looked at the appearance, whether they looked ill or well. Their age cutoff was 21 days, so less would be high risk, greater would be low. And then if they had any leukocyturia, they used a procalcitonin of less than 0.5, and then a CRP less than 20, and an ANC of less than 10,000. So for this article, the sensitivity was 92%, and the negative predictive value was just over 99%. So all of these babies had a urinalysis, a urine culture, a white blood count, a CRP, a procalcitonin, and then a blood culture. And really, if the urine and blood testing was reassuring, that they actually were able to skip the lumbar puncture. The intermediate risk was actually managed the same as the high risk. And what they needed in order to be classified as low risk is that, once again, they had to have a fever that was 100.4, it had to either be documented by them or a reliable source. It couldn't just be the tactile fever. They couldn't have other signs of infection, so they couldn't have any respiratory symptoms. They couldn't have like diarrhea or vomiting. They had to have a normal physical exam, had to be previously healthy, and then had to be a term baby. So they split the bacterial etiology into either invasive bacterial infections or non-invasive bacterial infections. And so once again, the invasive is going to be the meningitis and bacteremia, and then the non-invasive are going to be like your urinary tract infections, and then any other type of bacterial infection that they found. And so in this article, they found 23% did have a bacterial infection, and only 3.9 had an invasive, and then the rest had a non-invasive bacterial infection. So this is probably a little bit difficult to see, but this is just to give an idea of the algorithm that they used. And really it is just a step-by-step approach. So, the top, it talks about their pediatric triangle assessment. So how did they appear? Were they well appearing? Were they alert? Did they have anything abnormal to place them in the lower high risk category? And then did they have any work of breathing, and how was their circulation? And then from there, it would either be high risk or you just continue on down the steps. And so really, if any of these are positive, you're going to be high risk. But then once you get to the CRP and ANC, if those are elevated, then that would actually put you into the intermediate risk category. But once again, they were all still treated as the high risk category. And then if all of that was negative, then you were considered a low risk. All right, and then another article that may contribute to the AAP guidelines are in 2012 in pediatrics. So it looked at the costs and outcomes after implementation of the care process model of febrile infants. So this was an observational study that was done in Utah over several different facilities in several different cities. It was a 5-year study, so from 2004 to 2009, and they implemented their guidelines in 2008. So in this article, they found that 10% of their febrile infants evaluated had a serous bacterial infection, and that they were less likely to have a serous bacterial infection if they had a viral infection. And that they also noticed between their facilities that there was substantial variation in the care that they provided, even though they were still the same company, it was just different facilities. And that urinary tract infections were the most common in this article, or urinary tract infections are the most common bacterial infection for the serous bacterial infections, but depending on the facility that you looked at, only 19 to 70% actually had their urine tested. So for them, they also broke it up into high and low risk. And so to be high risk, you had to be less than 28 days if you were a premature baby, if you had some type of chronic medical condition, and then if your initial CBC or urinalysis were abnormal, then you were considered high risk. So the management without antibiotics was recommended for low risk infants for serous bacterial infections. The high risk infants, it was recommended that they received antibiotics, they were admitted, and they also had some type of respiratory viral testing. So when they were admitted, if they had culture negative infants that were at high risk for the serous bacterial infections, if they tested positive for a viral pathogen, or if they were low risk for serous bacterial infection, then they were eligible for the discontinuation of antibiotics and discharged at 24 hours. So even your high risk, looking at less than 28 days, if they were positive for some type of virus, and otherwise cultures were negative at 24 hours and they were well appearing, that they would actually discharge them and stop antibiotics at 24 hours. So a day earlier than what we previously do. All other culture negative infants were eligible at 36 hours to be discharged if they were well appearing, and all cultures, once again, negative. So all right, so 36% of the patients were positive for some type of respiratory virus. And they found that the length of stay decreased by 27%. So their average was 60 hours, and then they went down to 44 hours once they implemented these guidelines. And the performance of the lumbar puncture remained stable because, once again, those high-risk patients, the less than 28 days, currently as we do, they all obtain a lumbar puncture, and so that did not vary. And there was no increase in readmissions for serous bacterial infections, even though they discharged them at 24 hours. There was an increase in the laboratory costs in the emergency department because most of this workup is done in the emergency department, but they felt that it was offset due to the decrease in costs for the admitted patients. So the mean cost per admitted patient decreased by 17%, and overall in 2009 they had a savings of $1.9 million. And for their for this study, 85% of the bacteremia was reported out in blood cultures after 24 hours. And then the low risk had a 1.4% of the serous bacterial infections, and the high risk had the 21% occurrence of serous bacterial infections. So for the evaluation, all the patients had a urinalysis with microscopy, a urine culture, a CBC, a blood culture, and then an ALT and AST, really depending on the risk for HSV and if they were less than 42 days. And then they also had respiratory viral testing. They don't specify like what they all tested for, but that they were tested. So once again, this is very difficult to see, but just to give an idea of the algorithm that they used, so they actually had two different algorithms, one for inpatient and then one for the emergency room. And really, it kind of goes through the high, low risk category, you know, are they, their age, their appearance, any risk factors, and then they would either be low risk or high risk. And the low risk, when you go down, you know, at 24 hours, they could be discharged if everything was negative, or they could actually be managed as outpatient. It kind of depended. This is the hospital one, so they were already admitted. And then, of course, if either side had a positive culture, then they would be treated accordingly. If they had HSV, then clearly you would call your friends in infectious disease to kind of help guide your treatment. But if they had the bacterial culture and they were high risk that was negative, but they had a positive viral culture, at 24 hours they were discharged as long as they were well appearing. And then if they had negative viral and negative culture, but they were well appearing, they were discharged at 36 hours. And once again, this is difficult to see, but this is the algorithm that they used in the emergency room. So essentially at the top, if they answered yes to any of those, then they're going to be high risk. And then if they answered no to all of them, then they would be low risk. And then it just goes into, do they have a respiratory virus, yes or no? Can they be managed outpatient, or do they need a limited workup? And then either outpatient or admitted, and then the high risk were all admitted. And then the same thing then from there was if they had cultures, positive, negative, and then viral testing to determine when they were able to be discharged. This is just a closer look. But it's really difficult to see. So in conclusion, so the goal for the guidelines are really to identify the low-risk patients that would be appropriate for less evaluation, decreased length of stay, decreased exposure to antibiotics, and then also a cost for kind of all parties involved. And then here's my references. All right. Any questions? Oh, I'm supposed to ask, are there any questions from the outside facilities? Oh, all right. So, any questions here? Yes. So the question slash comment was, so after, if you discharge a patient at 24 hours or 48 hours, like who follows up on the labs? And so, I mean, I think that's a very good concern, because as of right now, you know, a different provider could be on in the hospital or the emergency room. And so it would be, you'd really have to look at making sure that those would be, because I think right now, all of the results go to the hospitalist. And so you're right, who's going to follow up on that? Dr. Galloway.
Thanks, Becky. Yeah, it's nice talking. This is a good topic too, because over the last number of years, it's been a pretty robust topic of discussion on PDAC hospitalists nationally, with robust listserv and also the national meetings. This has come up quite a bit. I just wanted to comment to a couple comments that you touched on in this. One is value-based care and risk tolerance. So the goal for a lot of this stuff is, how can we improve the value of the care that we're providing by having quality care, but also decreasing the cost, both financial risks, psychological stress for families, while still maintaining, again, good quality of care that we're providing. And so that's kind of the goal for a lot of these. And then, as you mentioned, how do we interpret and apply the data? Really probably comes down to risk tolerance too, in terms of both the provider's risk tolerance and family as well. So there should be a discussion with the family as well. Okay, if I have a 1 in 100 chance of missing a bacteria, how many kids what's my risk tolerance? Do I need to watch 100 kids? Do I need to watch 1,000 kids in the hospital for X number of times to risk missing one? So really it comes down to a discussion with the family based on the evidence. But so different providers may end up applying the evidence a little bit differently based on their experience. That's why the numbers is good.
Mm-hmm. 5,000 to 10,000, yeah.
Compared to the first 24 hours,
Maybe I have a few comments to make as well. Sort of the pro and con side of this argument. With regard to reducing the number of procedures, all of that makes sense. The issue there, I think, is that statistics are interesting, but they must be applied to that one case. And that's where I think our point is sort of taken, that involves an individualized decision based on the patient that's in front of you. Some of the things that we see when these guidelines come out is, unfortunately, they get applied across the board, and it becomes the rule of thumb. So our rule of thumb is that we discharge everybody after 24 hours. And that's where the mistakes happen, because you cannot do that. You've got to look at those criteria which we're talking about, whether they're low risk or high risk. You've got to look at those very, very carefully, because if there are barriers to discharge in terms of distance from the hospital,
And follow up.
access to transportation, those things, those are critical. In assessing those issues, and not just looking at the numbers and saying, oh, the numbers look good, this is a low risk case. There are social factors that you've got to take into account. So I think once that is done, you can actually use the guidelines very effectively to do the optimal thing. The other issue with the guidelines is the evidence. So Tom mentioned evidence. What evidence are we actually looking at? I would, I'm not getting personal, I would bet that a lot of the studies that we look at are observational.
They were.
They are not clinical trials.
Right.
So there are inherent problems with using observational data to make your guidelines. I think part of the reason guidelines are delayed is because they're moving to grade, and grade takes time to evaluate the evidence and then provide recommendations for quality of the evidence. So those are just some comments with regard to the guidelines process, how we should be applied once it's
Dr. Zylstra.
One comment initially is that
Oh, you can run them?
We do folk health.
Yeah.
We do CRP. And they're, but,
I know, I called Sanford and this is the price that they gave me.
so they,
Yeah.
less than but I think this is an interesting topic. It's one of the challenges that we have in medicine in general. You know, everybody easily goes to it to improving care, adding more things. Those studies are easy to show, to add, and everybody jumps on board on it. When we've done something for a while, and then it seems like now we're taking away therapy, that scares the bejesus out of everybody. Because we have an X risk, we have risk X now that we are comfortable with, and lo and behold, and I have to decide, is my other risk that I'm taking the risk of, oh crap, I missed one baby who ended up having meningitis that I interpreted wrong. And I mean, we've seen this with the bronchiolitis guidelines. We used to give NEPs for everybody, and it was painful to stop giving NEPs to everybody because we knew we were okay. We have it with the RSV synergist guidelines. You know, we have all these things that we're okay with, and then someone tells us that, no, we're going to save money and we're going to miss that. So these studies are good to do, but they're hard, I think, to implement, to convince physicians who are not for a while you've been more aggressive. Nobody ever tells you you've been too aggressive.
Right.
But this is the main reason you have guidelines. Because you're worried about safety, and that's why you have these guidelines that usually protect experts, and a lot of them are experts anyway, that you go and read and see what they think, and then you apply to your safety. And that's, so nobody would say you have to follow these guidelines, and you should not feel like you have to follow these guidelines, but at least you have somebody else has their experience and in a way read their experience doing their guidelines.
Francesca.
In my search for a future job, I've come across a term that's new to me, having spent most of my time in places that don't have this, and that's an observation unit, where a lot of places with emergency departments and pediatric floors kind of have this middle ground where we can help to pare down some of the cost and intensity of what we're giving while still getting the safety of lab monitoring. And so I was curious about, in your literature review, how many of those studies use those, talk about those, address that, and whether or not that's part of the future of monitoring.
So the question was about if there's any observational units that the infants could be watched instead of just admitted. And there was one study that talked about especially like if they hadn't had a fever or symptoms for very long and they didn't feel like the workup was going to be very helpful, that they did the workup, but then they watched them for a couple of hours. They had an observational emergency room area. They don't really give any numbers about how many of them were admitted from there, how many were discharged, but they did state that if they did present early, that they were watched. Kaylee?
The risk of issues with their microbiome, their gut flora, things like that with future illness. Dr. Chatterjee, do you have any idea, or other people in the audience, as far as exactly what we're putting them at risk for by giving them antibiotics, and maybe it's not warranted?
So there's
Febrile.
Just to add a couple of points regarding mainly the testing. I know that we are getting fascinated, impressive with good in testing with the molecular testing. Central lab is on top of technology, getting the most like recent technology lab molecular, but nothing is superior than your clinical judgment, and that clinical judgment from your experience with understanding of the guidelines. In molecular testing, we have a very good test here, which is the respiratory and penetrating and febrile infection. But the test is not 100% accurate, and those are very sensitive tests that even capture contamination, meaning that if the lab is having like some sort of, you know, procedure or something, they can get contamination. So these things have to remember just like look at the lab and it makes sense. Um, the example I can put is when you're testing like newborns and you have enterovirus, rhinovirus, maybe the respiratory panel, maybe you couldn't do an LP at that time, and then we have that positive result. Just remember that those tests detect small amounts of DNA, and it has to make sense, the clinical picture with that test, come to your judgment and say, you know, this test or this is what the patient is having right now. So do not rely solely on those tests, and that's why it's the same for CRP, for health and go by your clinical judgment and
Just one comment, and maybe not related to this, but I always say to my medical students, try not to overthink too much. You don't know what you're going to do.
Mm-hmm.
We a lot of times we send you tests. I've seen it in my specialty. Some person order a test and it was abnormal and then they stop. Like, if you don't know what you're going to do about this test, even if it comes to referral, like, okay, this is positive, I think it's going to to this. But I have patients who are at a random story council and someone does a test. I don't know what to do with it. Well, I don't expect them to know, but they just sent it. So, in general, every specialty, you should order a test and you know what you're going to do about it. Or not order it.
So Oliver, Joe and talk about that is what you should do is decide what are you going to do if the test is positive, and what are you going to do if the test is negative. And if the answer is the same, then don't do the test because you know it is meaningless. It's a humorous way to think about it, but it's a critical point. And there are plenty of studies that have shown all of the additional unnecessary testing and that follows because you've got one test that somebody's done that you've been obligated to follow up and do more testing and more testing.
And the actual what Dr. Brewer alluded to too is even if you do step-by-step studies.
Yeah, they talked about rhinovirus. Yeah.
81% of the time, just based on your
Yeah.
general appearance and their age.
Yep.
So that by before you even do any labs, you've made a diagnosis or made your clinical interpretation based on that in almost all the cases. And then kind of you'll refer back and using the guidelines. Yeah, this is probably why you can't just say, here's the guideline, this is what I'm going to do on every single patient. You have to interpret it based on each patient, interpret the lab results. Does it make sense for the patient that I see in front of me? Be able to apply it to that individual person and make decisions based on the guidelines and especially that particular pathway.
Nick.
So I want to get back to the prophylaxis moment. So based on the sensitivity and specificity that you show, it's helpful if it's negative, but not as much if it's positive.
Yes. Yep.
Talk about other conditions that can have a positive elevated prophylaxis that wouldn't be very sensitive.
So it didn't go into details about that, but the specific things that should elevate it were the things that we were looking at. So I haven't really ordered. Yeah.
me, I need to pay attention, something's not right. It's always how I tell patients, that's how I interpret it. Doc, pay attention, something's wrong.
Go back and look at where these inflammatory markers were at these studies. The CRP and its value in evaluating serious vaccine infections is really studied in skeletal infections, specifically for ulcerative. That's where in the study setting was shown to tell you the difference between the not a other than that, it really hasn't been studied in pneumonias, in meningitis, in bacteria. It has not been studied in the same way at all. So we just use it indiscriminately across the board to tell sick from not sick, which is not the way to do counting from not. You can ask for those outside questions now. They're really open.
I don't know if they're still connected, but anybody from an outside facility have any questions? Nope. All right, thank you.
It's hard to gauge.
Good job.